In this program, we'll be looking at one of the commonest problems encountered in surgery, fractures. Then we will talk about anesthesia, that state of controlled numbness. And lastly, we'll discuss the latest in heart surgery. The word surgery comes from a Greek word meaning hand. Originally, it meant the art of healing with the hands. Most ancient civilizations knew how to extract an arrow or reduce a fracture. But surgery as we know it today developed much later. Until the middle of the 19th century, the main quality of surgeons was their quickness. The most skillful could amputate a thigh in 4 minutes and an arm in 12 seconds. Fortunately, today we have other ways of fixing a broken arm or a smashed ankle. It's often toward the end of a great day of skiing, when we're tired, that the accident happens. A bad fall, a collision with another skier, a tree or a fence, and we've fractured something. Generally speaking, our bones are solid enough. They were designed to bear our weight, and they can withstand considerable pressure lengthwise. But they are less resistant to a transverse shock or a torsion, two situations that, because of speed, frequently occur on ski slopes. Today, very high ski boots have considerably reduced the number of tibia fractures, but they have increased knee fractures and sprains, which is not necessarily an improvement. Indeed, extra-articular fractures, like that of the tibia, affect the cylindrical part of the bone and are easy to heal. Intra-articular fractures occur at the end of a bone, at the level of a joint like the knee or the elbow, and are more serious. They will lead to long-term after effects, such as stiffness, blockage, or premature wear of the joint. First, to treat a fracture, for example, a fracture of the tibia, the injured limb must be immobilized because the swinging of the foot can cause additional injury. Any fracture will inevitably damage the periosteum that covers the bone as well as the muscles and tendons connected to the bone. Even when it does not break the skin, a fracture can damage the arteries, veins, and nerves. A fracture of the femur may also entail the severance of the femoral artery or the crushing of the sciatic nerve that controls the muscles of the thigh, leg, and foot. A surgeon must then restore blood circulation as soon as possible, suturing the arteries or performing bypasses. A damaged nerve can never be completely repaired. At the hospital, the doctor has x-rays taken of the injured area to decide on the treatment to be given. If it is a simple fracture, a clean break with the bone ends fairly opposite each other, all that is needed is traction and a cast. In the operating room, the orthopedic surgeon first covers the leg with a special stocking, a stockinette, to protect it. He then realigns the two bone ends while exerting slight traction. He immobilizes the bones with a plaster cast. He then has a control x-ray taken to make sure the bone is well aligned. The cast, which prevents the bone from moving, has to include the neighboring joints to prevent the slightest muscle movement that might pull on the fractured area. But it's not always that simple, especially in the case of a violent shock where a bone end may break the overlying skin. We call this a compound fracture. As soon as possible, the surgeon must cleanse the wound and bone thoroughly to prevent infection, always a possibility and always dangerous. About 5% of all fractures are compound fractures. For example, this type of fracture is very common in motorcycle accidents. Even if the skin is not pierced, the bone may be broken in several places. It is also possible that due to the interposition of tendons or muscles between the fragments of bone, the orthopedist may be unable to realign the two bone sections. Surgery is then required to get to the bone and, depending on the case, set it with a nail, a plate, or external splints, or fixations. In the case of a fracture of the tibia, the orthopedist immobilizes the bone by inserting a long nail into the marrow. He may also choose to install a plate that is screwed into the bone. External fixations offer a great deal of flexibility. 2 pins are stuck through the leg and fractured bone and are connected externally by metal rods. A wire that runs down the middle of the rods can adjust their length to either compress or lengthen the fractured area. In cases like these, it is not necessary to use a cast. The protective splints are sufficient. While nails and plates are made of stainless steel, they still have to be removed after a year or so to avoid making the bone too frail. Bones are living tissue, and if they are not allowed to carry any weight, they lose their mineral salts, become atrophied, and degenerate. A fractured bone starts to heal as soon as the 2 bone ends are realigned. A blood clot forms. The blood brings fibroblasts, cells that give rise to connective tissue in a few days. The clot turns into a tissue called a callus. Other cells, osteoblasts, deposit mineral salts in the callus that gradually turns into bone and brings the fractured bone ends together again. A bony bump forms around the fractured area, but it resorbs within a few months. This entire process can take no longer than 6 months in children, but up to 2 years in adults. Once it has healed, the bone is just as strong as before it was broken. For surgery to develop, anesthesia had to be discovered. For the first surgical operations, the patient had to be tied down and kept calm with alcohol and opiates. These rudimentary methods to dull sensitivity only allowed for simple operations. Anesthesia changed all that. Today, some operations can last up to 20 hours without the patient suffering any damage. Numerous medical procedures, particularly surgical operations, require that the patient be protected against pain. An anesthetist's work begins the day before the operation. He meets with the patient and chooses the type of anesthesia he will use, depending on the type of operation and the patient's condition. He explains the surgical procedure and reassures the patient. This in itself is a first step towards anesthesia, since a person who knows what to expect is much less nervous. When the time comes, a nurse administers a sedative, which allows the patient to remain calm, both while he's being transferred and during the waiting period. In the operating room, the anesthetist inserts a catheter, a hypodermic needle connected to a tube, into one of the patient's veins. Through this, he will inject various drugs designed to induce anesthesia, such as benzodiazepines, narcotics, that is, drugs to eliminate pain, and finally, pentothal, a barbiturate that puts the patient to sleep in less than 30 seconds. Since the muscles must be relaxed and motionless for the surgeon to operate, the patient is also given curare. Curare is a muscle relaxant that prevents the voluntary muscles from contracting. The heart continues to beat, but the diaphragm, the muscle located under the lungs, which is responsible for respiration, ceases to function. While inducing anesthesia, the practitioner monitors the patient's breathing. As he gives the patient the first drugs, he makes him breathe pure oxygen with a mask so as to saturate his blood with oxygen. Once the patient is fully under, the anesthetist removes the oxygen mask and inserts a tube into the trachea, the tract which leads to the lungs. The endotracheal tube is attached to a device that supplies a mixture of oxygen, nitrous oxide, and a volatile anesthetic agent such as halothane. Nitrous oxide is a light anesthetic. However, a product like halothane induces profound anesthesia. During general anesthesia, the loss of consciousness is much more profound than during sleep. While much of how anesthetic substances work remains a mystery, scientists do know that they obstruct nerve impulses at the level of the junctions between neurons. As for curare, it sneaks by where the nerves and muscles meet, taking the place of the neurotransmitters that normally stimulate muscle contraction and therefore induces paralysis. During the operation, the anesthetist monitors and corrects the patient's vital signs, such as respiration, pulse rate, blood pressure, as well as level of acidity in the blood. An oscilloscope displays the patient's electrocardiogram. An oximeter placed on a finger gives an ongoing reading of the degree of saturation of oxygen in the hemoglobin of the blood. The saturation rate should remain within 95 and 100%, otherwise an alarm is triggered. A recently developed device called a capnograph monitors the amounts of carbon dioxide and anesthetic agents exhaled. All these precautions are aimed at ensuring the patient's safety and immediately detecting any problem that might arise. Certain moments during the operation are more painful than others, such as the incision and exploration. The anesthetist anticipates these moments and adjusts levels of anesthesia accordingly, for example, by adding narcotics or by increasing the levels of the anesthetic agents the patient is inhaling. Once the operation is over, the anesthetist still has to awaken the patient and make sure that everything is fine. The administering of anesthetics already slowed down towards the end of the surgery is stopped completely. Gradually, the levels of anesthetics in the blood and exhaled breath decrease. The anesthetist injects an antidote that eliminates the effect of the curare so that the muscles function again and the patient can breathe on his own. During the next 24 hours, which is how long it takes for the drugs to be completely eliminated and for the patient to recover somewhat from the strain of the operation, the patient will feel drowsy. General anesthesia is essential for operations of the stomach or thorax. For limb surgery or minor operations like dental procedures, regional or local anesthesia is sufficient. This is done with products that block the conduction of impulses. Local anesthesia is achieved by injecting the anesthetic substances close to a local nerve. For regional anesthesia, the anesthetic is injected close to the spinal column, which deadens the feeling in the lower limbs and abdomen. For instance, an epidural given to women about to give birth reduces labor pain without preventing the muscles from functioning. Thanks to modern anesthetic techniques, complete surgical operations can now be performed without the patient feeling any pain. Even after anesthesia was invented, 1 out of 2 patients died from the aftermaths of an operation. Doctors didn't know why. Of course, they did observe what they called blood poisoning, or they would talk about local inflammation or irritation, but it was vague. The notion of contagion didn't even cross their minds. It was Lister, an English doctor, who first made the association between germs in the air, on the instruments, or the physician's hands, and suppurating wounds. Today, everything is sterilized, and surgeons manage to perform operations that would have been inconceivable only 10 years ago, among others in the area of heart surgery. Heart contraction is controlled by electric impulses from a mass of cells called the sinoatrial node. When they receive the impulses, the muscular cells in the ventricles contract simultaneously. Following an infarction, certain areas of the heart are not as well irrigated with blood and thus lack oxygen. When part of the heart is dysfunctional, the distribution of electric impulses becomes irregular, giving rise to heart arrhythmia. Following an infarction, two types of arrhythmias can threaten a person's life. In a tachycardia, the heart beats abnormally at a rate of 170 to 200 times a minute for 30 seconds or more. The ventricles do not have enough time to fill with blood before contracting and driving the blood into the arteries. Blood pressure drops, and the person loses consciousness. Fibrillation is another dangerous arrhythmia. In this case, the heart's muscular fibers contract in a disordered fashion, chaotically. The heart can no longer pump the blood properly. Such a condition can be fatal unless the heart is defibrillated, that is, given an electric shock to make it contract normally again. Today, arrhythmias are treated by implanting an apparatus called an automatic cardioversor defibrillator underneath the stomach muscles. This device permanently monitors and corrects the heart's electric activity. A cardioversor defibrillator is about the size of a pack of cigarettes. 3 wires connected to electrodes attached to the heart. A first electrode supplies the microprocessor with the patient's electrocardiogram. 2 other electrodes stitched onto the outer membrane of the heart will, if necessary, modify the heart's electric activity. Should the heart begin to fibrillate, the apparatus converts into a defibrillator and emits a brief, intense electric shock, and the heart beats normally again. If a tachycardia occurs, the device analyzes the signals, goes into cardioversor mode, and sends the heart an electric shock that puts an immediate stop to the tachycardia. Conversely, if the heartbeat slows down, the device goes into motion, sending the heart regular electric impulses to increase the heartbeat to a predetermined speed. Batteries supply the device with a life of 5 to 7 years. Once a defibrillator has been implanted in a patient's abdomen, the cardiologist can either activate or deactivate it from outside, change its sensitivity, as well as the tension and current of its stimulation. Besides arrhythmias, the heart can suffer other abnormalities, such as damage to the valves. Due to technical progress, medical science can now replace or repair these valves. The valves regulate the flow of blood to the heart. The mitral valve separates the left atrium and ventricle. The aortic valve separates the right atrium and ventricle. These valves, in the forms of small pockets, consist of a supple, fine, and resistant tissue. In a degenerative disease, such as aortic stenosis in the elderly, the valve tissues fill up with calcium and become fibrous and stiff. A valve may also tear or become obstructed. Afflicted persons have a heart murmur. The stethoscope reveals an abnormal sound. The cardiologist confirms his diagnosis with an echocardiogram. The image he obtains enables him to detect any obstruction, leak, or irregularity in blood flow due to the dysfunction of one or several valves. A heart surgeon is able to repair the mitral valve by sewing part of it up or by reducing its size if it is leaking or is only slightly damaged. For the aortic valves, or calcified valves, the cardiologist has no choice. He must replace the affected valve with a prosthesis. These operations are done under general anesthetic, with the heart stopped and an external device pumping the blood. Mechanical valves have 1 or 2 openings. Like a natural valve, the mechanical valve opens when the blood flows in one direction, but shuts to prevent it from flowing back. Theoretically hard-wearing, mechanical valves are, however, noisy. Moreover, they encourage the deposit of blotches and the formation of clots. People fitted with mechanical valves must therefore take anticoagulants for the rest of their lives and see their cardiologist on a regular basis. Heart surgeons can also implant valves of animal tissue, usually aortic valves taken from adult pigs. The tissues are then chemically treated to avoid rejection problems. The animal valves have the advantage of being silent and do not require the use of anticoagulant medication. However, like natural valves, they wear tear, or calcify after 10 or 15 years. Doctors must therefore choose the type of valve best suited to their patient, taking their age, work, and medical history into account. Surgery is developing by leaps and bounds. Soon it will be possible to operate on babies inside their mother's womb. Surgery and anesthesia, inseparable, have not yet ceased to amaze us.